Okay, hearing none, then it's my honor then at this point to present Dr. Mark Gormley. He's a pediatric rehabilitation medicine physician at Gillette. He treats children and adolescents who have cerebral palsy, brain injuries, spinal cord injuries, neuromuscular disorders, and other conditions. With a special interest in spasticity management, he joined Gillette in 1993. Dr. Gormley received his medical degree at the University of Louisville School of Medicine in Louisville, Kentucky. He completed his residency in physical medicine and rehabilitation at Tufts Affiliate Hospital in Boston, and completed a fellowship in pediatric rehabilitation medicine and traumatic brain injury at the University of Michigan Medical Center. Dr. Gormley is a distinguished member of the UCP Board of Trustees at National, and it's my honor, Dr. Gormley. I've worked closely with him in the past couple of years. He's also part of the UCP Research Committee. So with that said, an honor to introduce you, Dr. Mark Gormley.
Thank you, Armando. Appreciate it. Can you hear me okay?
Yes.
Okay. All right. You can go ahead and put up the first slide. I'm having trouble with this sharing my screen on this side. So during this whole process of being on the UCP Research Committee, it's been one of Armando's been unbelievably helpful. The whole board has been helpful. Graham's been helpful. And over the past year, we've developed this research committee quite well. And I'm going to talk a little more specifically about that. I'm talking about research a little bit as well. But I want everybody on the line to kind of understand kind of what we're doing and what our direction is. We had to pick something to start with when we started this research committee, and we picked cerebral palsy because it's part of the UCP's base. But it's not going to be exclusive to that. I think that initially we're starting off with looking at early intervention and early treatment as preferably looking at supporting that type of research. But ultimately, we're looking at adult services and all the other different services that the affiliates provide. And so what we want to do is want this research committee to be supportive of all the affiliates, not just specific ones, and hopefully to help develop care paths and treatments and allow some commonality. There is an initiative or a conference, I should say, an initiative through Cerebral Palsy Foundation this coming August at Emory, and they've invited the affiliates, and I'm mentioning this now because I don't want to forget. They have invited any affiliate that is interested to come and to get some training in early detection of cerebral palsy. Now, what the early detection means is less than a year of age, and going and helping develop whatever resources you have, whatever resources you're lacking, trying to work within those contexts to provide some of those services in early detection. So for affiliates, we're going to be sending out this just came up this week. We are going to be sending out messages to the affiliates that if you are interested, and it's the August 12th through the 14th, if you're interested in attending virtually or going in person to Atlanta, the person that's leading this charge, Dr. Natalie Mader, is going to provide a one-on-one support for the UCP affiliates. So I want to let everybody know that, and you'll be getting some more information about that for those. All right, you go ahead. Okay. Yeah. All right. And actually, there's a third slide, Armando, but I don't think it matters that much because the first slide, the second slide is really basic. Research is, yeah, we can just stay with this. This is a couple of my more favorite quotes regarding knowledge. Charles Darwin said, "Ignorance more frequently begets confidence than does knowledge." And then Mark Twain said, it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. And so I think this is a good example of what happens when we think we know what's going on. And we're really confident about what we feel. No, you can go back to the other one. I was going to talk a little bit more. But I was going to give you a couple examples. Can you go back?
There it is.
Yeah. Oh, that's just going forward. There we go. All right. Whoop. That's what. There we go. Stop there. Okay. All right. We'll stop there. That's all right. That works. So there's a couple of examples. I don't know if you all know the ghost map. It's the study of cholera back in the 1800s in London when they had a big cholera outbreak. At that time, the dogma was and all the scientists and physicians felt that this infection, cholera, was from bad humors and smell. And so it's the bad smell of the slums that was causing all the disease. And there was an epidemiologist that just wouldn't take that. And he made a map of everybody that was dying and went through the slums of London. And basically he helped develop germ theory. And then that evolved from there. But people were confident and they laughed at him, but it ended up he was right. And it was through his diligent research that he came about to help with germ theory and actually came up with mechanisms to eliminate cholera from London. Now, I'm from Kentucky. I grew up in the heart of the horse industry. And there's another study. There's medications called bisphosphonates that are medications used most commonly for elderly women for osteoporosis. And they use it in horses because it's supposed to decrease fractures. And horses are like deer with people on their backs running really fast. And so they got these spindly little legs and they break down all the time. So they started, they thought, what if it works for elderly women with osteoporosis, it should work for our horses. So they started putting on it. And what they found is that, and they were confident it was going to work, but what they found is that the horses were actually breaking bones more and they were breaking down more. And when they went and investigated it, what they found out is that in actuality, it wasn't preventing fractures, it was actually increasing fractures because it was not allowing for bones to heal as readily. It was decreasing the amount of calcium coming out of your bones, but it wasn't allowing it to go back in. And that's what bisphosphonates does. And so through their research and Delta research, they eliminated it. Now horses are made, they're running and they make money. And so they were sure to stop using bisphosphonates in race horses, but we're still using them for women that have osteoporosis. They don't make as much money as race horses. Okay, go to the next slide. So these are just two examples of where research really changed what the dogma was and what we were overly confident about. Now, I had a urologist when I was in residency who had a mother who lived in London back in the 1920s, and she worked in a lab with Alexander Fleming. Now, Alexander Fleming was a scientist that was looking at bacteria and trying to study it. Now, he had a bunch of people that were working in his lab, a bunch of mostly young women, and was working them to the bone. And they would bring in their lunch because they worked through their lunch hour. He was telling me these stories that when they would come in, they bring in their lunch. What they were discovering is that as they had these petri dishes and they're trying to grow bacteria, the ones that got bread mold on them wouldn't grow bacteria. And so they hated that. They hated when they got the bread mold. And so they're telling Dr. Fleming that, they hated when these bread mold. He's like, what are you talking about? He goes, well, when we get bread mold on the petri dishes, they don't grow bacteria. And so he got a great idea. Go, let's study the bread mold. So it found that's where penicillin comes from bread mold. And this gives you an example of a petri dish with bread mold on it. And that was serendipity. It was just the women coming in, bringing in bread, and they didn't look like the moldy bread here, I'm sure, but bringing in enough spores that got on the petri dishes and grew. And he found out from that in that regard. And you also get unexpected consequences when you do research. We did a study looking at urinary tract infections after surgery in our hospital at Gillette. And what we found is that the longer you leave a Foley catheter in their bladder, the more likely are to develop urinary tract infections, and that's a bad thing. So we decided we're going to pull every Foley out after at least within 48 hours. So we did that, and we found that the urinary tract infections went down quite considerably. But then what we also found is that in children that had surgeries called a rhizotomy on the lower part of their spine, they started having urinary retention. They didn't have urinary retention before. So we went back and retrospectively looked at their data and found out that what was happening is because we were pulling the catheters early, that the bladders were shutting down, and most of the bladders, if you leave the catheter in for 5 days, they didn't have urinary retention. They were having urinary retention between days 2 and 5, and we had the catheter in previously, and they didn't have that problem. And so once we started leaving the catheter in longer, it eliminated that issue, and that was a bigger problem than having urinary tract infection. So again, you can do research and you can do it serendipitously, and you can be really confident about certain ideas and concepts, but you have to continue to look at the information that you're given and the consequences of the changes you make, and with additional research to make sure you're doing the right thing. All right, next one. So in clinical medicine, there's a couple of different types of surgery research we look at. We look at what's called clinical medicine, which is more kind of global, and it looks at adding knowledge about human disease prevention and treatment. So for example, clinical research may be, does salt increase the risk of high blood pressure? Now that doesn't tell you about treatment, it just sees what is a risk factor. Same with fatty foods and cholesterol, heart disease. And then also another type of clinical research would be incidence of genetic disease and cerebral palsy. One of the chairs of the research committee, UCP research committee, Michael Kruer, is world renowned in looking at genetic diseases and cerebral palsy. But again, that's not treatment, that's looking at kind of incidence and what risk factors may be. Now, translational research is a segment of that. And translational research is taking knowledge and trying to apply it to a treatment to affect a disease. So you're basically trying to treat a disease. And so does a medication help high blood pressure? Does treatment of infants of cerebral palsy improve? If you treat them early, does that improve their outcomes? And so that would be translational. And that second one, treating infants with cerebral palsy and early diagnosis and treatment, does that alter their life course, is one of the initial initiatives of the URC. Next slide. Okay, so I'm gonna break down, there's different types of studies, research studies that you can do. And I'm just gonna give you some basic examples of that. I think most people understand this, but there's case studies, and that's looking at 3 or fewer patients. And people may think, well, okay, well, that's only N of 1. What value is that? Well, if you have a rare disorder, that could be very valuable. So I'm in a clinic, a complex movement disorder clinic, and we get rare genetic disorders in there. And we have children that have various different movement problems. And there's a procedure called a deep brain stimulator that can help some children with movement problems. And sometimes we don't know if that's a good idea or not, because we don't have experience with these rare conditions where there may be 30 in the world that have been identified. And if somebody has gone and done a case study and reported, they had one patient that had this exact same genetic disorder, and they did a deep brain stimulator and it was effective, then that gives you a little bit of solace that this may be a good treatment option for them. And if enough people start to do that, then you can collect all of that data together to help optimize treatment. Now, probably the most common way of doing research is what's called a retrospective study. That's basically going back and look at old medical records and trying to tease out information to see what associations are there in the information you got to look at treatment and prevention and things like that. And the urinary tract infection study was one of those studies, like a retrospective that I illustrated. And the problem with those is you have data that are oftentimes missing, and there's biases that go in there. Now, the gold standard for research, however, is the randomized double-blinded placebo-controlled trial. That's basically taking a group of patients, divide them into 2 or 3 groups, assign them to a treatment protocol, and one of those treatment protocols being a placebo, so they're getting some kind of sham treatment. And the physician or therapist or whoever's involved in that care don't know, the patient, the family don't know. The only person that knows is the pharmacist or whoever may be organizing the treatment, the only ones that knows, and they don't tell anybody. And so then you try to figure out, is it the treatment that's working, or is it just the placebo effect that's working? Go to the next slide. Okay, so even though the randomized placebo-controlled trial is the gold standard, it is fraught with all kinds of issues as well. Now, it is necessary to get FDA approval to go through a randomized placebo-controlled trial, because that is the best way of doing this study. And it is very, very effective in trying to figure out information. But you can have certain biases and issues. They're expensive, and time consuming and difficult. And I'm gonna give you an example. So there was a group in Boston, just to illustrate some of the limitations of a randomized placebo-controlled trial, is they try to look to see if anybody had studied parachutes and to see if they actually minimize death and trauma when you jump out of a plane. And nobody has done a double-blinded placebo-controlled trial of a parachute. So they decided, okay, we're going to do that. So they're going to do, so they took a group of people, they divided them in half. Half of them got a backpack with a working parachute, and the other half got a backpack with a parachute that didn't work. And then they were going to have them jump out of a plane. Now, the problem is that they couldn't get anybody to jump from 10,000 feet in the study. And so, but what they did get them to do was jump 2 feet from a plane that was sitting on the ground. And what they found is that there was no difference between the people that had a real parachute and the people that didn't have a parachute. So they published this in the British Medical Journal, which is one of the top medical journals in the world. And it was a very, very well-designed study, except you can understand that there were some limitations to that study. And so they did that in jest just to demonstrate that even the best of studies can have some problems and some biases that are inherent in them. And so no matter what you're doing in research, you always got to question, is this the right thing? And that's why you have to replicate studies and do all those different things, is that a double-blind placebo-controlled trial can be very, very powerful. However, there's always limitations no matter what the study is. All right, go to the next one. All right. So I'm going to give you 2 examples of where a double-blind placebo-controlled trial came into play. And these are 2 studies that I was involved in. So this is a study with Dysport. It's like Botox, so the medication that you get for wrinkles, but also we inject it for adults and children with spasticity to loosen up their muscles. And Dysport's kind of like Advil versus Motrin. It's kind of the same medication, it's just a different brand. And this was looking at a multi-center trial. There's like 30 centers across the world, and looking at what we called a physician global assessment. So basically, it had a scale, and if you graded somebody 2 points higher on this scale, then that meant that it was working, it was doing better. So they had 3 groups. They had a group that had a high dose of Dysport, a group that had a medium dose of Dysport, and a group that got placebo. And nobody knew which one they were getting. I didn't know. So I'm hoping that I was on the good end of these determinations, but I didn't know. And what they found is that 90% of the people that got the high dose did better, that 87% of the people that got the medium dose get better, but 63% of the people that got placebo got better. So 63%. So this illustrates that if we had just done the placebo trial, let's say we didn't have a blinded and have another placebo, if we just did the placebo, that 63% would have been a statistically significant improvement. So that would have been enough to say, hey, this stuff really works. But in reality, it would have just been a placebo. So placebo always works. But because the real stuff works significantly more than the placebo, the FDA approved this medication for treatment in children. So Dysport is now approved. Now, nope, you got to go back. The best one's left to go. The second half's good. Botox. So Botox, another study looking at the same thing, looking at a group of kids and looking at the modified Ashworth scale. So this is looking at how tight your muscles are. In this scale, the higher the number, the worse it is. So you want the number to go down when you get the injections. And so in this study, what we did was we injected these kids, and then we measured how tight their muscles were. Now, if you look at these graphs, there's 3 lines here, and the graphs went down, the lines went down. That means their tone got less. That means they were less tight. So that's a good thing. So, and again, just like the Dysport study, we had 3 branches. So we had a high dose and a medium dose, and then we had a placebo. Now, all 3 of them went down, including the placebo. Now, botulinum toxin lasts about 12 weeks, and everybody kind of knows that. So if you look at the bottom line, the treatment line there, the people that got the real stuff, you notice after 12 weeks, it's starting to wear off after 12 weeks. And that's what you would expect because it naturally wears off. But if you look at the placebo line, it also wore off. So even though people got a placebo, they started getting tighter after 12 weeks, even though they got just saline injected. So that tells you how powerful the placebo effect is. And if you have trouble understanding American politics, you can look at these 2 studies, and it helps illustrate that you believe what you want to believe. And that's what happens with placebos. Okay, you move on. So both of those studies got approved because the real stuff actually improved much more. Now I'm going to talk about translational research. And again, I've already touched upon this, and this is real world types of treatments where you take a treatment and you try to see if it has some efficacy in improving the lives of individuals. And so what translational research does, not only does it look to see if a treatment helps, but it also helps developing programs, and it adds some structure to your program so that they're gathering the same kind of data. You're doing the process in a way that's efficacious and safe, and all those different things. And so that's the beauty of research is that it helps you develop a whole program within your setting, within your community that helps the treatment protocols, but it also helps in perpetuating that treatment well after the research project is done. And so that's going to be the emphasis of the research committee is that we're going to focus on translational research, initially children with cerebral palsy, but we're going to expand upon that at a later time. And we're looking to establish and improve treatment protocols across all the affiliates at UCP. We want them to feel some value in doing this research, and we're going to support you along the way. If you're new to research, this committee is going to support you in writing the grants and figuring out what you need and you don't need, and things like that. So we'll hold your hand through the whole process, but we're hoping is that it'll help develop your programs, and it'll allow you to do some research and collect some great information so we can optimize those treatments as we're going forward across all the affiliates. Okay, next slide. All right, so that was the impetus for the research committee through UCP, and to look at initially looking at cerebral palsy and other related disorders, but ultimately to expand upon that with all the services the various different affiliates provide. Okay, next slide. So here are the co-chairs. I've mentioned Michael Kruer already. He's a pediatric neurologist from Phoenix, and Valerie Piericini. She's a nationally renowned occupational therapist, and she's a world beater. She really has made this committee run, and she's in Phoenix as well. And so these two people have really made this happen, and they've done a wonderful, wonderful job. I can't say enough about it. Okay, next. All right. So the mission of UCP, I think everybody here understands that it's indispensable. We're trying to be an indispensable resource for individuals, communities, and families for cerebral palsy and other disabilities. And the URC is wanting to promote the highest and help establish the highest quality care for children and adults with cerebral palsy and related disorders, and then help expand their programs. Next slide. So this is just a snapshot of what the committee is. Right now, there's 13 stakeholders, at least I think it is. We've kind of evolved a little bit from there. The committee, it's important that we address what we think the affiliates as well as what the community needs are. And so as part of that committee, we have two people with cerebral palsy. So we want to make sure that their voices are heard. We have two people who are parents of children with cerebral palsy. So we want to make sure that their voices are heard. And we have people that are on the board of trustees. We also have a group that are associated with UCP affiliates. And then we have one representative from NIH and researchers and clinicians. And so this is an all-star group. This group is really, really, really good. I mean, it's one of the best CP groups in the world, I would say. And we've gotten a lot of help, like I said, from Keith and Armando. So, and then also I got to mention Kismet. She's the consultant that we've got involved in. Man, has she done a wonderful job. She has, I mean, she's taken it to heart to make sure that UCP does a good job with this. And I can't say enough about her either. So as I said before, this research committee is looking to support research in the various different affiliates. We're going to oversee funding. We're going to get research grants. We're going to help you vet all that. We're going to provide some infrastructure and resources for new as well as existing research. So if you already do research, we hopefully can support that and promote that and advance it as well. And then also looking at short-term goals, but we also, again, one of the impetus for this is to establish long-term programs with affiliates that they can continue and helping you develop that along the way. Next slide, sorry. All right. So why cerebral palsy? Well, we had to start someplace. And we started cerebral palsy because that's the basic mission and the origins of UCP. It's expanded since then, and we understand that, and we're going to expand our focus as well. But we started with that. One of the newer things and one of the newer treatments that are out there for cerebral palsy is early detection, early intervention. Recent studies have shown that if you start to treat a child before a year of age with cerebral palsy and identify it early, then you can actually alter their life course. It doesn't cure the cerebral palsy, but it improves certain elements of that. And so we're trying to promote that. We're trying to get affiliates that deal with children with cerebral palsy to learn how to detect in an infant if they have cerebral palsy, and then helping to establish a treatment. So that's the reason why we started in that area. Next. And why translational research? We want to make sure that we're having a direct impact on the patients that the affiliates are seeing. We want to make sure that we're improving the programs that are there and improving the outcomes and treatments that are provided through the various different affiliates. And so that's why we focus on translational research. And then we also want to help develop programs, and that's the best way to do it. And why is UCP? Well, UCP historically has been very involved in research, and they're very involved in supporting the community in general. And we thought that by expanding, and the research has become less of an emphasis in the recent years, and then so more recently, in the last couple of years, by reviving some of that, so that we can help advance some of the programs in the various different affiliates and provide some commonality. What we're trying to do is trying to provide basically a better service for the affiliates. We want to make sure that they feel supported and that there's some commonality between the various different groups. All right, so there's 58 affiliates. There's 39 that serve children, 17 provide early intervention, and there's 20 affiliates that provide some pediatric therapy services. Not all provide see kids with CP, but at least initially, some of the research grants that we have coming out will preferentially be looking at that. But if there's not a lot of affiliates that have that do programs in CP, but there's an adult program that has a wonderful research idea, we're going to support that too. There's going to be at least initially some preference towards the CP initially, but if that interest isn't out there, we'll divvy up the dollars to the adult services as well. So we encourage everybody to submit something. So this is one of the initial. This is kind of an evolving process too, and I'm not going to go over all this in detail, but just to tell you that we have some money that's been designated for research, and we're doing a pilot program. We're not just going to open up this program all at once. And so the initial pilot program is going to be $60,000, and we're going to fund 2 to 3 studies of about $20,000 to $30,000, kind of depending on what comes in and what they estimate their costs are going to be. And then we're also in the process of looking at raising money on an ongoing basis, and we're hoping to raise $5 million over the next 5 to 10 years. And then depending on where the monies are and what the interests are, expanding the services from there to a more formal research grant program with various different tiers. And I'll talk about that in the next slide. And so these are the 3 tiers ultimately that we're looking to push for. There's some entry-level ones when you're starting some new research, some basic research, some just a few patients just to try to figure out how to make these your research program work. And that's 25 to 100,000 on average. There's tier 2, which is 100 to 200,000, and then tier 3, which is the upper tier. And this is when the programs get to be more mature, be 200 to $500,000 $500,000. And in those tiers, you're looking at trying to put together enough information that you could get an NIH grant or something else like that. So this would be a really big initiative. But these are pretty standard, the 1, 2, 3 tiers. And this is what we're looking for, pointing to ultimately to get to. All right, next slide. So in summary, so the URC, or the UCP Research Committee, is going to provide support to the affiliates. We will advise on any kind of grant applications if you have them. If you don't need it, that's okay too, obviously. Encouraging those new to research to apply, because we want to help you along the way, because it can help with a lot of different program development and then new initiatives that you may be interested in. We're initially going to prioritize grants to the affiliates, but it's not going to be exclusive to the affiliates. So if there's an affiliate that's working with a community-based program that really could use some help in this regard, we encourage you to put in a grant for that as well. We will prioritize translational research in CP, but like I said, depending on what comes in and what the highest quality proposals are, we'll support adult and other services as well. And we'll expand the grants ultimately to all the different services that the affiliates provide, even if you don't see kids, but doing adult services. But again, the goal of this whole research committee is to improve the quality of care and to help develop services at your affiliate as well as in the community. Now, you can go to the next one. I'm going to show you a couple of examples where translational research, and these are my slides and my videos, and I'm giving you my greatest hits. So not everybody looks like it works out quite this well, but these were all translational research, and I'm going to show you some of the effects. All right, you can go ahead and click on the first one. There you go. So this is a child with cerebral palsy. And she's born prematurely. It says a significant amount of spasticity. And we were wondering if she was treated with spasticity reducing injections with botulinum toxin and phenol, if that would help. And this is her a month later. You can click on the second slide, or picture. And this was her a month later. So she had a significant improvement. And these kinds of studies is what helped us optimize the treatment of kids with spasticity at our institution and helping them walk. All right, the next one. Here's another example. This is actually, you can show the first one. This is actually the first patient we treated with Botox at Gillette back in 1994. So she's an adult. She has cerebral palsy. She has she's a hemiplegic on one side. She has a family. She works full time. But she had this one right leg, or the right arm too. She had the right side that was really, really tight that interfered with her ability to walk. And so braces didn't work. The surgery wasn't effective for her. And so we did some injections. And we'll show you her this is her a month later. So it significantly improved her walking. She went from walking like 400 feet at a time to walking 4 miles nonstop, literally a month afterwards. So she was extremely happy. Now, the second picture is her 25 years later. Now, she gets injections about every 4 months, and we've had some gaps in there, but in general, and she looks almost exactly the same than she did a month after the first injection. So she's had a wonderful, because it lasts, like I said, 12 to 16 weeks. She's had a wonderful outcome, and she continues. She walks, she's in her mid-50s now. She walks better now than she did when she was in her mid-20s. So it's been very effective. And this person in general, I'm not going to tell you the whole story now because we don't have time, but this person in general, because of her and her videos, expanded the acceptance of Botox by the insurance companies throughout the United States. It's a fascinating story, just her. So all right, let's go to the next slide. But again, this is translational research and how much it helps in program development. All right, this is a different procedure. This is a rhizotomy. So this is a similar child. He's got spastic diplegic cerebral palsy as well. And he walks on his toes, and we couldn't get him off his toes. And we did a surgery called a rhizotomy, that lower part of the spine. All right, go ahead and click the second one. And this is him a year later after that surgery. And his walking is almost normal. He looks pretty good. He looks very good, actually. And then 2 years later, let's click on that one. This is him running. He's virtually normal. You can't see any difference in his gait. Now, and that's extremely rare to have someone look this good after rhizotomy, but it just gives you an example, again, where some of the translational research can be helpful. And these are the kinds of things that we want to help the affiliates to develop. You may not be wanting to get into rhizotomies or anything like that. We understand that, but we want you to be able to develop some kind of, improve your programs and expand your programs. All right, go to the next slide. We expanded our program to Jamaica. I go to Jamaica 3 times a year before COVID, and starting to go again in a few weeks. And this is the first child we did a rhizotomy on. And this again, translational research, we collect the data on this child to look at what the pitfalls and what the advantages and disadvantages of the treatments and within that context, because Jamaica is a lot different than the United States. Is it working? There we go. This one has sound, but I'm not sure you can play my video with sound. So this is Tennyson. And Tennyson, his mother was a teacher at a middle school, but Tennyson wasn't allowed to go because he couldn't walk. So even though he's bright, he's very, very bright. And we did a rhizotomy, and this is him several months later. He was walking, so he could go to school. Tennyson actually ended up graduating number 4 in his high school class, and they do the British system, so everybody knows where they are when you graduate from high school, what rank you are. He was number 4. So he started off not being able to go, and now he can go. And now we're doing those treatments. Again, there's a translational research, and the support we get for that research is what's made these kind of differences. All right, next slide. I'm going to show you, this is constraint therapy. This is the early detection, early intervention. This is a hemiplegic child. And you can notice his left arm, he doesn't hardly use it at all. He doesn't use it at all, actually. And trying to put him on there, get him up to do that. And there's a treatment called constraint where you put a cast on the good side, and you force them to use the other side, and you hope that they develop some skills. So if you hit the second one working, there we go. Now, this doesn't seem like much, but that's way more than he was doing before. And so he's starting to utilize that left hand as a helper because he's playing with the ball. You see the cast there. Now, again, all these treatments aren't going to be a cure, but we're looking just to start to improve. And if you do brain scans and things like that, you see that actually how the cortex is organized changes because you do this. It stimulates it and it tends to mature and grow where it wouldn't have been before. Now you can go to the next one, next slide. Now, Armando, if you can go from left to right on each one, we'll go from the top and then we'll do the second row and then do the third row. So if you go ahead and click the top left one, yeah. So this is a similar child, and this is him trying to bang some cymbals beforehand. Now you can click him afterwards, and this is after he completed treatment. And he instantly picks them up and does better with them. I just saw him in follow-up last week. He's doing remarkably well. I mean, his left arm isn't perfect, but man, is it really improved. And we continue to do some constraints periodically on him. I'm not going to go into great detail about that, but if you're affiliate and interested, these are the kinds of things that we would talk to you about if you needed some help. Okay, let's go to the second one. Just give me a couple more examples. Yeah, you can show the second one. Yeah, there you go. So again, lining them up much better, much quicker to use that left hand than it was before. All right, you can do the bottom one. Yeah, there you go. Now, before he wouldn't even play with the Legos very much. And you see he's struggling with his left hand there. All right, you can show the second one. Now he seeks them out. Before he had to be encouraged, and now he's pulling things apart and putting them back together and transferring. And transferring is a big deal. I mean, if you watch him transfer from his right hand to his left hand, and when you do that, you know you're utilizing and integrating your left hand, whereas before they just ignored. They never transferred over to the other hand. So these are just some basic examples of how constraint-induced movement therapy, early detection, early interventions can really alter a child's course. All right, that's it. So that's all I got, I think, Armando. Does anybody have any questions? I think I've run the time.
We still have time for questions.
Okay.
There's a question about the UCP research initiative and how to apply. It looks like you can go to research at ucp.org if you're interested in that grant.
Yeah, I'm sorry, I should have mentioned that. Should have had a slide on that, actually. That's my fault. Yeah, but it's online and it's open till the end of June. I think June 26th is the deadline to submit.
Right, June 27th we have here.
June 27th. Yeah. Okay, got it.
Okay.
And then it'll be a review process of like a couple months, and then the awards will be handed out in September. So this program that's in August, we can't get within that timeline. That's why this is kind of going to be a little bit of a carve out. So if you're interested, and we'll be reaching out to you, but if you're interested, please let us know. I'd contact Valerie Piercini, and we'll put together the affiliates that are interested and do our best to get people either there or at least involved in that program.
Any questions for Dr. Gormley? So this presentation will be, it's been recorded and it will be in the UCP affiliate portal for anybody else that wishes to, anybody on your staff or folks that could not make this meeting. I do want to thank Dr. Gormley. Thank you for your presentation. Every time I watch those videos, you know, I just see a miracle happening, and I think you've done a lot of that. And I'm really excited about the research committee. I think everybody knows that, and what can be and the impact that we could have, not only just with our affiliates, but also in the world, really, for children and adults with cerebral palsy. And what I understand, Dr. Gormley, is that whatever breakthroughs come about through research, it also can affect positively those that have other different conditions. So, you know, I look forward to that. Any questions before I have a couple of closing remarks here and some announcements?
Armando, I just want to point out to everybody here that's on the line here, and particularly the affiliates, is that UCP is still a big player nationally. Since I've been on the board of trustees, I can't tell you how many meetings people have asked me to be involved in just because I'm part of UCP. It still has a big influence and a big impact, and we want to make sure that it still continues to do that in all the different ways that UCP can. So I appreciate all the affiliates that are out there and all the work that you do, but we want to continue to try to help you too.
Thank you, Dr. Gormley. So a couple of announcements at the next quarterly town hall meeting, and thank you, Cheryl, for this. She introduced us to Mr. Chris Newland. Chris Newland is the executive director of the National Children's Advocacy Center in Huntsville, Alabama, and he will be speaking to all of us about child abuse prevention and intervention services. That's August 11th, 2022. Please note that there is a time change because we wanted to facilitate the time for Mr. Newland. And it's going to be, instead of noon Eastern time, will be at 1 o'clock Eastern time, but you will get information from Carrie, and maybe you've already got that information. But then also, quick announcement, the South RAC is meeting in person October 6th through the 7th in Orlando. Then the West RAC and the Northeast RAC are contemplating I'm not sure if it's going to be a virtual or if it's going to be an in-person meeting in June. So stay tuned for more information. And I want to thank each and every one of you for being on this call. This was a great presentation, Dr. Gormley. Oh, we do have a question. Cheryl, yes.
I was just going to share that, and thank you very much for today's presentation. I did want to share about the next one. Chris Newland is a parent of a young adult with significant disabilities, and he has a personal interest in tracking maltreatment and issues and statistics related to disability. So it will not be just a general child abuse and neglect topic that you usually hear. It will be actually centered around our populations.
Excellent. Yeah, thank you, Cheryl. Appreciate it. All right, so with that said, then everybody have a great day, and thank you so much for being on this call. Goodbye.
Bye.